with NGS. Angela is a consultant hematologist at Oxford and is the medical lead for hematological cancers for Central and South Genomics Lab. Dr. Hamlin.
Brilliant. Well, thank you very much for the invitation to come and talk to you about NGS, measurable residual disease. I have to say I always feel a fraud because I'm not a myeloma doctor. I'm very much more on the genomics side of things. But there we go. So just by way of background, and I think quite a lot of my talk has already been covered, the NCI definition of MRD, so measurable or minimal residual disease, is a very small number of cancer cells that remain during or after treatment, which you need some sort of highly sensitive laboratory technique to detect. And I'm sure everybody knows this, but the potential benefits are you can work out just how well your patient is responding, where they've actually plumbed to and the depths of their response and what the prognosis associated with that is, and also whether they're not doing quite as well as you think from their conventional treatment monitoring, and whether you want to then intervene early. So, as I say, I work mostly in genomics, so I spend most of my time looking at this and wondering about that variant, does it actually mean anything? And what I really want is to know what's happening here at the protein level. And of course, the MRD we've spoken about already is very much focused on the protein level. So what are the proteins expressed on our cells for flow cytometry? And what are the proteins which have been secreted in terms of your immunoglobulins by mass spectrometry? But maybe in the context of measurable residual disease, I might argue it the other way around, because if something is going wrong here, is it really the most sensitive way, what you're seeing as the protein? Are you more interested in actually what's happening at the genetic level? And that's, I guess, the basis of MRD using genetic techniques. Traditionally, this was your ASO, so your allele-specific oligonucleotide PCR. So this is your kind of qPCR, which underpins our ALL MRD in this country. And then more recently, as NGS has flourished in our laboratories, that has kind of become the new kid on the block. So what would we want to look at in NGS? Well, I'm sure most people here will be very familiar with Dr. Gooding and Co.'s myeloma gene panel, which gives you many potential targets. But with the exception of the immunoglobulin translocations, most of these very much come and go across the course of disease and are subclonal, and you don't really want to measure anything subclonal. So we're back to our good old immunoglobulin B-cell receptor rearrangement, and that's what underpins most of the NGS MRD for myeloma. So I'm going to talk about the analytical validity of the testing, a little bit about clinical validity, but you will see a bit of deja vu with lots of my slides because you've seen them already, and then just a little bit about some of the logistical considerations. So first of all, thinking about the analytical validity. So this is all predicated on the fact that we have a very clever mechanism for making our B-cell receptor. We string together VDJ segments in order to get that diversity for your heavy chains and VJ segments for your light chains. And this is done in an imprecise fashion with extra nucleotides coming and going, meaning that any B cell should pretty much have a unique DNA sequence. This then means that you can pick out if you've got an abundance of one sequence over everything else. And so underlying the different assays which are available, and I have to say, I should thank Adaptive for a number of my slides. I feel like I might be, advertising clonoSEQ. I'm talking a lot about clonoSEQ because it is FDA approved, because it is furthest down that regulatory road. There are other assays available that people are using. In VivaScribe, for instance, people are using for MRD, and people are also developing their own in-house homebrew assays as well for obvious financial reasons. But the basis of all of these is that you do a multiplex PCR, so you have primers which will amplify any of these VDJ or VJ rearrangements for your heavy and light chains. And then you do some next generation sequencing of your PCR products. And you should detect a dominant clone or clones for rearrangements. So initially, you need to detect your clone. So you will want to amplify and look at everything. And then when you're doing your tracking, you still amplify everything that's there, but you're really only interested in the things that you found at the beginning. So you can do a comparison. When it comes to anything that involves PCRs and lots of cycles of it, the risk of false positives and erroneous results become quite a thing, and therefore there's a lot of kind of bioinformatic backstory to this. There's a very developed bioinformatics pipeline. There's some very clever things done with the primers. Some primers bind better than others. Some primers amplify better than others. So you need to have compensations and balancing of those primers. And when it comes to deciding what are the dominant clones that you're interested in, they have to be a big enough percentage of what you've analysed. There needs to be enough starting molecules, so 40 starting molecules at least, and bearing in mind you're sequencing about 100,000 cells initially when you're trying to find your clone. You need to make sure that there is some level of polyclonality in the background and you haven't just literally, I don't know, managed to amplify some cell line knocking around. The expansion of what you're calling your dominant clone needs to be significantly different from your background polyclonality. And then finally, it's got to be significantly different from just a whole pile of standard, normal, healthy B-cell rearrangements, so that you're not just getting some erroneous amplification of something which is ultimately a false positive. And when you've calibrated against all of those things, about 90% of patients with myeloma will have a suitable clone or clones that can be tracked using this method. Then it comes to your rather deeper sequencing. So by deeper sequencing, I mean in your MRD sample, you need to sequence between 2 and 3 million cells to actually hit that 10 to the 6, so 1 in a million level of sensitivity. And on the left, it's just demonstrating that cells will not necessarily distribute themselves evenly. So at 1 in a million, you can't just sequence a million cells, say it was negative, because you haven't found anything. You need to sequence rather more than that just because of your normal statistical distribution. And in terms of the level of detection and the level of quantification, I think the best way of describing this is you're trying to work out what is above background error rate. So your level of detection is if it's a noisy room and you can just about hear someone whispering. That is your level of detection when you can pick up that whisper. If you can actually hear what they're saying, that's the level of quantification. That means that you can reliably and reproducibly actually work out how much of your MRD is there. And then this limit of the blank is working out the probability that some false MRD is going to be called. That's usually pretty low because of the nature of the sequences and being calibrated against that normal panel of B cells and the repertoire that you have there. And I guess that is, erroneously hearing voices and hearing a whisper, which isn't there if we're using that analogy. You've seen this slide before, and this is just looking that there's pretty good correlation between flow and NGS MRD. A lot of things I've seen, NGS tends to sometimes call a little bit more frequently than flow. It's difficult to know what your counsel of perfection and gold standard here is. Often there are some confounders because if first pool goes to flow and then you get the remainder of the sample for your NGS, you imagine that might be a little bit more hemodilute. And whereas with flow, you've got some idea of actually working out whether there's some hemodilution. If you're just receiving a sample and extracting DNA, you've got nothing to calibrate that against. With anything like this, where it's obviously there is the potential for false positives, you need to have very rigorous both internal and external quality assessment and assurance. And this is just going back to clonoSEQ, looking at an interlab comparison, which showed that across sites, using the clonoSEQ assay, doing the wet work, and then submitting the data to go through the central algorithm, actually the correlation was extremely good. This is not for onward sharing, but are the results of the EQA scheme, which is run by NetQuas LI. And I can say this one was actually negative. So you can see that 3 out of the 14 people who took part in the scheme, and this is international, this isn't just in England, and I suspect there's not many participants in England, actually called MRD in a sample which was negative. And this kind of just indicates some of the difficulties associated with it. Then whizzing on to clinical validity, and you will have seen a number of these slides before. So first of all, going back to Nikhil Munshi's meta-analysis, doesn't matter what your MRD technique is, it correlates with improved, if you're negative, with improved progression-free survival in this, and actually also overall survival. Looking just at clonoSEQ, if you were, this is a Spanish cohort or several Spanish trials, patients where they had samples they could look back at, demonstrated that if you were MRD negative, your overall survival and time to progression, and this was using 10 to the 5, so a little bit less than the kind of 1 in a million, perhaps gold standard that you would say for NGS. Then looking at the level of MRD, exactly as we've seen before with the flow, the lower your level of MRD, the better your prognosis in terms of progression-free survival. And then just thinking about, can we push this MRD further? Usually to get, as I showed you on the earlier slide, to get a level of 10 to the 6, or 1 in a million cells, you need to sequence about 2.5 million cells. Once you want to start sequencing more than that, you're going to have an incredibly expensive test on something which is already quite expensive just because of the amount of sequencing space you're going to need to take up. And so this was a study where on the right they actually enriched your starting plasma cell population by taking 8 mils of bone marrow and sorting for 138 cells and then doing the MRD assay. So they reckon that their sort of target sensitivity was 10 to the 7 here. And it shows that actually the lower you go, so if you're less than 10 to the 7 versus less than 10 to the 6, actually your progression-free survival is even better and your rate of reacquisition of MRD positivity is even better. So NGS MRD is mentioned in a number of guidelines. This is the IMWG definitions of responses. It's in the NCCN, and it's also in ESMO guidelines. So it has kind of worked its way in there, although I'm not aware of anywhere in this country where it's being used routinely. So what about the logistical considerations? Again, you will have seen this before, and so I won't go through it in a lot of detail. But compared to flow, I guess the advantage of your NGS MRD perhaps is that you can hit those slightly lower depths of MRD negativity, although what does that mean? That's something that always needs to be worked out. Also, your sample doesn't have to be processed immediately. It can be stored and then onward processing, but it is very expensive and there's no getting away from it. And as things stand at the moment, I would suggest it is significantly more expensive than any of the other MRD that we've spoken about today. The next kind of issue is, this is a genomic test. How do we get genomic tests in this country? Well, they're all funded centrally via the test directory. So therefore, if we wanted to be offering this, it would need to be funded centrally by the test directory. It would have to get onto the test directory, which is quite challenging at the moment. The test directory also doesn't actually specify proprietary assays. It would just talk about, in this situation, immunoglobulin rearrangement, NGS MRD, and there would be a tariff attached, and people would be asked if they could deliver it. To get proprietary technologies paid for, they have to basically go through nice technology appraisals one way or the other. So what about future developments? Well, clearly we're talking about bone marrow here, but people are looking at using NGS MRD with peripheral blood, or even thinking about circulating tumor DNA because of the potential for catching the extramedullary disease there. But I think, we need to walk before we run here. And then just finally a word, because I get lots of questions filtered to me from other people. I'm looking at you, Dr. Gooding. We are trying to set up clonoSEQ in Oxford in a collaboration with the university there. This is obviously outside the Commission test directory because it's not on the test directory at the moment. We're working on it. It is not a trivial thing to set something like this up because of the level of ISO accreditation, regulation, etc., etc. And I should thank everyone who's kind of helping us with that. And I'll start up there.